Hey guys, Woodruff here. Now we're going to get into the big three, and the big three are going to be UTI, kidney stones, and BPH. So these are the ones that have a lot more to them. You're going to see them more on NCLEX, HESI like tests. They probably have more questions than others on our exam coming up. So definitely want to pay close. Oh my goodness, I can talk. Pay close attention to these because they're also going to be ones you're going to see commonly in practice, like especially when we're talking about UTIs. Like it's a very rare month I can get through without having a patient that has that doesn't have a UTI. So so it's very frequent, and no matter where you work. Especially if you work around women, so definitely going to see this a lot. So a UTI, or a urinary tract infection, it's the most common bacterial infection in women. It's most often caused by the bacteria known as E. coli or Escherichia coli, however you say that. And what's happening here is normally the urinary tract is a very sterile, clean place. But sometimes those defense mechanisms that help to keep it sterile and clean are broken down, and this is what leads to the infection. So those mechanisms that can be broken down is like a chemical malfunction, like there's a change in the pH to the urine, and there can be a change in the pH because women, we like to make our hoo-ha smell like just wonderful, delicious. And so we use a lot of products and stuff on ourselves that can change it. There's also medications and other things that can change it. But yeah, like the soaps and other things that we use down there can affect it. There's a variety of things, but it's kind of the same as think like with the GI tracts, the GI tract, how like if we give antacids, it changes the pH, which changes the absorption of medications and how the GI tract works. It's the same with this. If we change the pH in the urinary tract, it stops it from being as clean of a place, and it stops its ability to fight infection the way that it's supposed to. The other problem could be a mechanical malfunction where there is, a sphincter that's supposed to stay closed. Sometimes that sphincter gets weak, childbirth, other fun stuff. So that can lead to bacteria being able to travel back where normally it wouldn't if that door was well closed. And then a big one is going to be user malfunction. So like hygiene issues, whether because of obesity, other things, or just lack of education. Many people do not wipe front to back or the way that they're supposed to. So it can be another cause. I think I have some more on the next slide. So big risk factors. We already talked about urinary retention. That urinary retention is a big factor, and that again, if your urine is having stasis or staying still, it's going to be more likely to hold on to or grow bacteria. Catheters and devices too. So like we just talked about Foley catheters and other urinary devices. Anytime you have anything in you that's not you, you're going to have an increased chance of a urinary tract infection. Poor hygiene is going to be another one. So people that don't keep themselves clean or have good hygiene practices, or again, that wipe back to front. Because the big thing, a big risk factor is for UTIs is being female. And the thing I didn't bring up on the last slide is that we have shorter urinary tracts, and then we also have a pee hole and a poop hole that are very close together, whereas men, theirs are very far apart and separate. They have it take a lot of work to get them close together, where they could get that bacteria from their stool into their urinary tract, where for women it's a lot easier. Use of feminine hygiene products. So this is like talking about like douches, all the stuff we like the different creams, powders, what do you call it, fragrances, body washes, and things that we do again to smell like a flower. But in the result of that can also mean that we get an infection. And then diabetes, because you have to think about these patients are going to be more likely to have glucose coming out in their urine. If they have glucose coming out, glucose is just a breeding ground for bacteria, and can lead to higher chance of infection, and they're already at risk for infection because they don't have good immune defenses. Constipation as well. We talked about this a little bit with incontinence, but if you have a whole lot of stool that's sitting in your rectal area, that's just bacteria chilling, building up. what do you call it, a very big defense, and then sometimes it can start to spread. So if I have a bunch of stool just sitting in my rectum, it's more likely that some of that bacteria from that stool can get to my urinary tract. And then we talked about with pregnancy, and pregnancy is actually a pretty big factor. It has multiple factors to it. What do you call it? The fact that, we have to go more frequently, it's harder to clean appropriately and things like that. But being pregnant is another big risk factor too. So there's some different terminology with UTIs, depending on where the urinary tract problem is what kind of urinary tract infection it is. So we have what we call a lower urinary tract infection. That's going to be the same as cystitis. This is like or if you hear bladder infection, that's what most people, when they say they have a UTI, it's what they have. It can spread all the way up to the kidneys, and that's where we have pyelonephritis. If you see that pyelo, that's another word for the kidneys. This is a kidney inflammation infection. You can then get systemic infection from that, what's called urosepsis, and this is what I see a lot of in the ICU, is patients coming in, they got a UTI, it got so bad it spread to their body. And then you can have just an inflammation infection of your urethra itself, which is the tube that goes from your bladder to the outside. But usually if your urethra is infected, it is usually going to go to your bladder. Hold on a sec. I felt a sneeze. All right, I think it's gone. Your book also talks about a complicated versus an uncomplicated urinary tract infection. And the difference there is just, do I have a slide? I don't think I have a slide with it. Like a complicated UTI is one that's complicated by the fact that a patient maybe has diabetes, that they have like some sort of risk factor that's going to put them at risk for getting a systemic infection, or there's something else going on, like it's more severe, where an uncomplicated UTI would be like, if you or me, we don't have a lot of health history, a lot of medical problems, got a UTI, it would be uncomplicated. Oh, the other reason, like a complicated one would be like, oh, because I have a Foley catheter or something like that. We're not going to give you like deep questions or be like, oh, which of these are complicated UTIs versus uncomplicated, but just know that there is a difference there, and you might see it in a chart where it says this is a complicated UTI or uncomplicated. And if it makes sense, complicated, it's complicated by devices, complicated by other medical history, complicated because it's more severe, whereas uncomplicated is just straight up, they got an infection and they have a good chance of being able to recover from that. So let's do a drag and drop the assessment findings that would indicate a client is experiencing a urinary tract infection. So the first, so we're just looking for what we would find in their urine that would tell me that they're having a urinary tract infection. It doesn't tell me whether it's lower or higher, so these could be for either or. So let's see. The first one is red blood cells present. So pretty much saying, would I expect blood in the urine? Now, if you've never had a urinary tract infection, which I was surprised, I want to say, I don't know if it was this semester or last semester, I asked, I was like, hey, on one of my units, I want to say it was last semester. And yeah, there was like a group of 4 or 5 nurses, and only like one of them had a UTI. And I was like, where are we living? Like, most people have experienced this. But if you haven't, you can have bleeding as one of the signs and symptoms. So red blood cells present is something I would expect. Urine, white blood cells present. There's an infection, and where there's infection, there's white blood cells. So that's something else I would expect. You might also see what's called pyuria, or like pus in the urine. Protein present. Now, this is where most students say yes, but the answer is actually nope. Protein in the urine is a sign of kidney issues, like my kidneys aren't working, they're not filtering the way they're supposed to. And this should not happen unless they're actually going into like kidney failure, kidney disease. It's not about infection, it's about kidney problems. So this is a nope. Casts present. Now you might be like, what the heck is a cast? We haven't talked about them yet, but the answer is yes. This is only though for upper urinary tract infections. So what happens is that when you have an upper urinary tract infection, sometimes some of the tissue can slough off or get broken down, and as a result, these like the cast or the dead tissue from the kidneys starts to slough off into the urine. So this is actually pieces of the kidney. I'm not saying it's like crazy, but it's like little pieces of the tissue of the kidney that have been inflamed and let go of. So what do you call it? Effectively the the cast being present, it would be true, but only in an upper UTI. I would not see this if they had a lower UTI. And remember, lower UTI is bladder, upper UTI is kidneys. Positive for nitrates. This is another positive. So they can have nitrates. It's another sign that they have a UTI. Positive culture. It's also another one that we would expect. No, when I did thumbs up, I think my thumbs up looks pretty stupid. All right, I'm gonna stop doing that. So positive culture is going to be another thing because that tells us that something is growing right now in their urine. Bacteria present, that's going to be another thing we are going to expect. Maybe I should get someone with like a cool thumb or a picture like of a thumbs up. But yeah, I'm not that cool. Like every time I think that like I could never be like a YouTube star or anything like that, I make a horrible what do you call it, presenter. Like I have ideas in my head of how like it will go and it never turns out the way that I hope. This is why I was really meant for small stadiums, like a small classroom of 30 people or less. Even less is better. And even then, now I'm even doubting that. I don't even know if I should do that. But yeah, I'm not much of a presenter, so I apologize for the nerdiness, but I do the best that I can with what I'm given. Some of us were meant to be indoors, and yeah, I always sometimes I think about maybe doing these videos without the camera anymore because I never wanted to do the camera. You know, students begged for it and said it really helped, you know, to see me or see me talking and for like whatever gestures, things I wanted to do. And so I was like, okay, I'll do it. But just now I'm sitting here wishing that I didn't have this camera on, and now I'm very self-conscious about my hands. So yes, I'm only going to have like 15 complexes after making these videos. Anyway, bacteria present, that would be a yes. And then glucose present. A lot of times students say this too because they remember how there's something with glucose and urine. And that's with diabetes. It's not necessarily, it's not going to tell me there's infection. It's just going to tell me there's extra glucose. So what I would expect is red blood cells, white blood cells, CAS, if it's upper, nitrates, a positive culture, and bacteria. We'll talk about some more things as we move on. Let's talk about general expected symptoms. So there's going to be that like I've hallmarked or kind of marked the ones that I see as like the most common, the ones that you're going to be like, this is it. This is a UTI. So if they are complaining of painful urination, like, hey, it burns. If they're what do you call it? You know, complaining about, hey, I've been going really often or frequency. And then if they feel like I have to go right now, the frequency, urgency, and dysuria or burning are probably the most common hallmarks you're going to see with UTIs. And we're talking about lower UTIs, but a patient with an upper can have all these symptoms too. Other things we might notice is blood in their urine. They might have trouble starting their stream or leaking, like some incontinence. They might have trouble with completely emptying and things like that. So I'm going to assess for pain or any difficulty urinating. I'm going to assess the urine itself and see what it looks like and possibly assess their temperature. With a lower UTI, they don't necessarily have a fever, but it's usually more with the upper, but it's possible. For an upper or like the pyelonephritis, you know, when the urinary tract where the infection spreads, most of the time people start with people don't usually start with an upper, they usually start with a lower and then it spreads. But it is possible to start with an upper. The patient's going to have the same symptoms as the lower, except they're also going to start having systemic symptoms like flank pain or kidney pain, chills, fever, fatigue, and loss of appetite. So think like GI symptoms, that flank pain or that pain in the back, and then like signs of infection. We're going to assess their urine. And remember, what's different in their urine? We're going to see CAS. And then we're also going to ask about the location of symptoms, any pain that they're having, because again, their pain might be in a different area. It might be more in the back area versus in the lower abdomen. We're going to assess those other symptoms, take their temperature, and then it's possible that if they get a kidney infection, they could get urosepsis. So we also want to assess their blood pressure and look for shock. So UTI in an older adult, this patient usually presents differently in the sense that a lot of times they come in with no urinary symptoms. It's really hard to tell. Like I'll tell you in general, if you have an older patient that comes in and they're confused, disoriented, it's probably some sort of infection. Might be a urinary infection, could be a lung infection, but it's just that confusion, that onset is really common for infection in the older adult. Abdominal pain is also another symptom where they might just have pain and nothing else, or they might just have general weakness and fatigue with no pain. It's like we talked about in the urinalysis, we're going to look for bacteria, white blood cells. Leukocyte esterase is another thing that we can find in a urinalysis of someone who has a UTI, nitrates. We talked about RBCs, the pyuria, all that stuff. So we're going to start there. Now, what they do first is they do what they call at my hospital, it's like a UA reflex with culture. And so what I do is I draw we're going to get a culture and I draw the UA. They start with just the UA. If the UA looks bad, like it has presence of a certain amount of these, then it's going to, automatically get them to do a culture, like pretty much it's saying, hey, based on these results, you need a culture. And if you remember, a culture tells us what specifically is growing, and then we can get a sensitivity that tells us this specific branch of E. coli in this person is going to be most sensitive to what antibiotics. As there's a growing resistance the E. coli has to a lot of antibiotics that we've used for years, which we'll talk about. We might do an ultrasound just to make sure that there's no complications or anything's going on, but usually we just have to do the urinary testing. When you're drawing a sample for a urine culture, just remember we always want to make sure to do it correctly, do it sterile. And we do that by, if they have a catheter, we want to draw from the sterile ports. What we do is I clean this off with a chlorhexidine. We have these cool things at my hospital that we can attach directly to these and then just stick the tubes in, but you can also draw up with a syringe. Or if they're going to do a clean catch specimen, which probably most patients that you take care of will be doing something like this, what we want to do is have the patient, we usually have them wipe first, start peeing, but don't pee in the cup, pee a little bit, and then put the cup under, because usually that first little bit of urine can be contaminated with some bacteria, and we don't want a false positive. All right. So a client with a UTI is better if they have less pain or symptoms like frequency and urgency, decreased or no fever, a negative urine culture, or maybe improvement in their urine clarity. And it's getting worse if they have more pain or more persistent symptoms like frequency and urgency. They have a new or worsening fever. They have a persistent positive urine culture, like their culture is not improving or becoming negative. And then any signs of systemic spread, so signs of that upper UTI or signs of sepsis or shock, things like that. So there's a couple medications that we can use. The big medication to actually treat the problem is going to be antibiotics. But there's other meds that we can use to help with symptoms. So this first one here is phenazopyridine, is probably how you say it, also known as azo, if you've ever seen it, it's over the counter. People take this. Now, here's the thing. People start getting symptoms of a UTI and they take the azo and think like, oh yeah, this is going to help me with my UTI. But here's the thing. It doesn't treat the UTI. It just treats the symptoms. So it's not going to actually fix the problem. Now, it can decrease their symptoms so that can kind of seem like, oh yeah, this is helping, but it doesn't change the fact that you have bacteria. It's not an antibiotic. One thing to tell them, it can turn their urine orange or red, so be very careful with that. And then also, like I mentioned, the big treatment's going to be antibiotics. We usually start them on a broad spectrum, or we have a few kind of go-tos for UTIs that it usually covers the bacteria that we're going to find. But it really varies. And your book talks about a variety. I'm only going to talk about, I think, 2 or 3, maybe only 2 antibiotics that we commonly use, but just know there's others. It just depends. If we end up like we don't get a culture on every patient, but if we do get a culture, then we may change up the antibiotic depending on what's growing. For example, if it's a fungal and urinary tract infection, we'll need to change it to an antifungal. So lots of antibiotics are becoming resistant to the E. coli. So sometimes these don't always work, but these are probably the 2 most common antibiotics you're going to see prescribed. There's I think they call it like, I think it calls something like I don't remember what your book calls, it's like SMT or something like that, but it's a sulfa drug. I'm going to call it Bactrim because I can't say that without dying inside. So it's a sulfa product, so you want to always assess for allergies to sulfa. A lot of people are allergic to sulfa. And then assess skin, because sulfa can also cause like rashes and itchy stuff. Then there's also macrobid or nitrofurantoin. I don't know if I'm saying that right. Maybe. Sounds pretty good. This one has a lot of possible side effects, like it can, the liver and kidney function can be affected. They can have peripheral neuropathy. It can also change your urine brown. And note, there's a couple of these that change your urine color, so you probably want to know those. Maybe put those on your note card. And then also just then they should report if they have chills, cough, chest pain, dyspnea, or a rash, because there are some side effects. But all antibiotics have a lot of side effects, so just be aware of that. When it comes down to it, for both these antibiotics, there's going to be some general stuff on the next page, but just keep in mind, I know these antibiotics worked if they have, negative culture, improving symptoms, things like that, where of course, these are the signs that you want to think of. Here's a sign of a problem. The other thing you want to consider, if someone's on an antibiotic and their symptoms aren't getting better, then what's the issue? Well, maybe we're not on the right antibiotic. So if someone's taking an antibiotic that we prescribe them and it's a couple days later and they're not getting better, their symptoms are staying the same or getting worse, then that's a time where they usually need to come in. We need to get a culture if we haven't already. But otherwise, we need to really look at how we're treating them. Are we actually treating the problem that's at hand? Is there something else going on? Yeah, antibiotics should start working within a couple days and should lead to improvement in symptoms, and then they should have a negative culture. So remember the generals for antibiotics. Finish all antibiotics. Like I said, if it's not improving in a few days, they may need to get a culture if they didn't do one originally, or get an additional culture, because sometimes, we can end up with multiple infections, or maybe it is E. coli, but it's drug resistant, so we might need something else. We want to always assess for allergies, because a lot of people have allergies that are related to antibiotics. Always check kidney function, because the kidneys are really sensitive, and a lot of antibiotics are harmful to them. There's lots of drug interactions with these, so keep an eye on that. Always watch out for super infection, and super isn't like super great, it's like super C. diff. So always be looking for diarrhea as a possible side effect. If they're starting to have that, you want to assess or maybe get a culture for C. diff. And then the most common side effect that people complain about with antibiotics is the GI side effects. So like nausea, vomiting. So taking it with food helps minimize those side effects. And just making sure, like a lot of times these days we're giving IV push antibiotics. Those should be pushed slowly. I think most of the time it'll recommend to push it over 5 to 10 minutes. Take that time. I know it seems like a lot of time, like, oh, I don't have time for this, but I've had some patients like just projectile vomit after those. You want to be super careful with those IV push antibiotics. And then just kind of taking food with the if it's oral can help a lot with their nausea. So my nursing focus is going to be pain management. I can encourage the patient to have heat packs to their lower abdomen or back. Take a warm shower or sit in a tub of warm water can help temporarily to relieve their pain. So warmth helps, in other words. Promoting hygiene, so aseptic technique, encourage regular personal hygiene and hand washing, and then encouraging fluids. They need lots and lots of fluid, flush out that bacteria. Safety precautions when using the restroom, because they're probably going to have to go frequently. Make sure they have a clean environment, a safe environment, the non-skid socks, bed alarm on, fall risk precautions, that stuff. And then I need to do regular assessments to make sure things are getting better. So I'm going to be asking about frequency, urgency, dysuria, those hallmark symptoms I told you about. It always depends on the patient. If they're not having any symptoms, then I might have to assess something else, but I always want to look for improvement in their initial symptoms. So let's do another teaching practice here. So a nurse is discharging a client with a urinary tract infection. What information should be included in their teaching plan? Select all that apply. Oh, your favorite. So use the bathroom every few hours. So with this, I want to think about like what I need to include. Will this help someone who has a UTI? So using the bathroom every few hours would be helpful, because it could help them, to make sure that they're emptying, getting all of their bacteria out, and not having any retention. So I think that would be helpful. I don't want them to be retaining their urine, because it could lead to a worsening or new infection. Take a shower before and after sexual intercourse. Well, I know we want to stay clean. I know we want to pee before and after. I don't know that you necessarily have to take a shower before and after. I mean, that's a personal choice between you and your higher power. But, I don't think specifically that would be something I would require a patient to do. It might be too much. Increase your intake of high fiber foods. So this one you might first be like, nah, because like, that's a GI thing. But remember, what did we talk about? Constipation. So if I have a bunch of stool sitting at the end of my rectum, it can't come out because I'm constipated. It's going to put me at higher risk for infection. So this is actually something we do want. So higher fiber means less constipation, which means less chance of urinary tract infection. Avoid using tampons or other feminine hygiene products. So I know we don't want the feminine hygiene products, but I don't think tampons are included in this. And so this is one of those where, you have to make sure that the whole answer is wrong or right. And so, when we look at this, even though I don't want them to use feminine hygiene products, tampons, unless they're scented or something special or spicy, they can be used. So, and again, don't read too much into this. Well, how do I know whether it's a scented tampon or not? Just say yes or no for tampons in general. Can we use tampons? Tampons are a feminine hygiene product, but that's not considered because a lot of times students ask this. They're like, "Are they allowed to use tampons?" Yes, we are. Um, we just want to make sure they're, of course, changing them out regularly, etc. The things we want to stay away from are like douches, sprays, and things like that. They're going to actually change the pH. And sticking a tampon in yourself should not change the pH again, unless it has something weird on it. Avoid spicy foods and decrease your intake of caffeine products. So those all sound like irritants. So I was going to say that's good to do. So I'm going to teach them to use the bathroom every few hours, increase their intake of high fiber, and avoid spicy foods and decrease their caffeine intake. And on top of that, so empty bladder regularly and completely. You need to empty your bladder before and after sexual intercourse just to help to get rid of that bacteria. Evacuating the bowel regularly, so avoiding constipation, wipe front to back. To avoid getting stool in the wrong direction, drink more water, at least 6 8-ounce glasses a day. Plenty of water. Avoid those feminine hygiene products like we talked about, not tampons, but others. And then encourage consumption of cranberry tablets or juice. And one caveat I want to say here is that in themselves, these can help to prevent, but they're not like a magical cure and they're not used to treat. Like once someone has a UTI, they can drink cranberry juice, but that's not going to change their UTI. Again, we have to give them antibiotics. Like it's not the cranberry that's going to fix this patient, even though it can help support a healthy urinary tract. And then again, avoiding those bladder irritants like caffeine, alcohol, citrus juices, chocolate, and spicy food. So yes, all the good stuff as always. All right. That's it. I'll see you next for kidney stones. Bye.